Well, I appreciate everybody being here this morning. I don't have to tell you that this has been a year of suffering and death. From the medical side, it's been hard on everyone, but there's something to be said for having lived the COVID-19 pandemic as an infectious disease specialist. I mean, after all, this is a virus, and in some strange way, we feel like we should own it. But you know better than that. It's the frontline providers who have owned this. It's the EMTs and the emergency room docs and the intensivists and hospitalists. And but I'll say this: we will own the end of it, because social distancing, masks, and hand sanitizer aside, it's vaccines that will finish the job. So this morning, Victoria Statler, who I knew as a second-year medical student and tricked into doing infectious diseases, is here to tell us about those vaccines. Daniel Blatt, our newest faculty member who came here from Brown University in Rhode Island and is about to experience his first derby, is here to tell us how we can help move these vaccines into people's arms. And Shanna Barton, as you know, is a homegrown whippersnapper, soon to graduate fellowship and about to become a faculty member. And she's here to share some thoughts about vaccine hesitancy and how it can be addressed. I just want to say that I would not have wanted to navigate this pandemic without this medical community that we're part of and this hospital, but in particular, without the people in my division. They are so smart. They are full of energy, they're dedicated, and they're willing to step up to the plate to solve problems. I truly feel blessed to have them, and I know that you're looking forward, as I am, to hearing what they have to say. So Judith, I'll turn it back over to you.
All right, well, this is Shanna, and thank you, Gary, for that introduction. And on behalf of Victoria, Dan, and myself, we are excited today to talk with all of you about the various aspects of COVID-19 vaccination and help you address some questions you may have received from patients, their family members, or maybe even questions you've considered for yourself. These are our disclosures, and these are our learning objectives for today. And first, I just want to show you some encouraging news. Whereas once these graphs were used to describe rising case numbers, we now see them as part of the vaccine response, illustrating the total daily number of vaccines that have been given since the initial rollout in December. And from a numbers perspective, it is amazing to see that over 101 million people have received at least one dose of the vaccine, and over 57 million people are fully vaccinated. And just to give you an idea of the impact you've made in your own community, looking just at Kentucky, over 2 million doses have been administered. Encouraging still is the percentage of Americans who have transitioned from the once hesitant wait-and-see perspective to already having had received their dose of vaccine to enthusiastically responding that they would like to get vaccinated as soon as possible. And yet, despite these promising trends, the wait-and-see or vaccine hesitant category is persistent, and the percentage of persons who state they will definitely not get vaccinated has largely remained unchanged over the last several months. The extent of vaccine hesitancy and refusal is pervasive. It affects persons of all socioeconomic groups. It's varied by country and even among individuals within the same community. Even before COVID-19, the WHO had declared vaccine hesitancy as one of the top 10 threats to global public health in 2019, and the problem has only persisted and has progressed to even include death threats against vaccine advocates. Now, what are some of the reasons that adults report vaccine hesitancy? Now, the list is broad, and the concerns are similar to those reported in response to routine immunizations, as well as several unique to COVID, including concerns about the development and approval process, concerns about becoming infected from the vaccine, and perceived low individual risk from infection, as well as concerns about vaccine efficacy in general and against new variants. But we're pediatricians, and so what are our caregivers saying in response to childhood vaccination against COVID? Overwhelmingly, the response has been positive, with the majority of caregivers reporting intent to vaccinate their child, followed by recognized importance of herd immunity and the role that children play in achieving this measure, and a desire to return to normalcy. Yet, as with adults, caregivers also cite concerns about COVID-19 vaccination in children. Common reasons include skepticism about the developmental process and the general novelty of the vaccine, perceived low risk in children compared to adults, and simply wanting to gather more data before consenting. And my personal favorite of vaccines need to be abolished is just not what we have time to unpack today. We have also seen these concerns played out at the local level, with feedback from our general pediatric colleagues illustrating similar themes, as well as distrust in the government, a questionable validity of the pandemic itself, and persistence of refusal in persons with a history of hesitancy. Now, to help address these questions and to provide you with a more detailed understanding of the data supporting the use of the COVID vaccine, I'm going to turn it over to Victoria for further discussion.
So thank you, Shanna, for that great introduction to this part of the talk. So before I really get into my part, I do have a few additional disclaimers. First of all, when we first started working on this presentation 2 months ago, I was a little worried that we weren't going to have enough information to talk about. Well, it turns out since then, a lot of information has come out, and something new comes out every single day. So we've tried to be as up to date as we can, but we will not be able to talk about everything today, and there are definitely topics like Shanna's and Dan's that absolutely deserve their own lectures. Obviously, our ID group is always available for questions, either after the presentation or later next week or next month, but I just did want to say that we probably aren't going to be able to talk about everything today. And then the other thing is that while most of us here are pediatricians and we're interested in the data on vaccines in children, right now the only information we really have is data in adults, definitely as far as effectiveness and safety is concerned. But hopefully that's going to help us answer some of these questions from patients and families now. And then when we do have more data in children, it will provide a framework for those discussions later on. So there are currently 3 available vaccines in the United States. Each of them is under an emergency use authorization from the FDA. And each of them right now is actually has a working name that you can see in the left-hand column. For today's talk, however, and for ease of discussion, I am going to refer to these vaccines by their manufacturer names because I think that's just what the public knows and what we all know and how we refer to them when we talk about them day to day. The first 2 vaccines listed here are the mRNA vaccines. They're the first to get through the approval process or the authorization process made by Pfizer, BioNTech, and Moderna. And they were authorized within a week of each other last December. Now, they're the 2 that we have the most information on because they've been distributed for a longer period of time. And so you'll hear a lot of the data today that I'll be discussing will be about the mRNA vaccines, although we'll talk about the Johnson & Johnson vaccine as well. Now, there are a couple of differences between these 2 mRNA vaccines from an administration standpoint. They're both 2-dose vaccines, but the Pfizer-BioNTech vaccine has a 21-day interval between doses, whereas the Moderna vaccine has a 28-day interval. And they are both approved for adults, but the Pfizer-BioNTech vaccine is approved actually down to 16 years of age. So you may have some patients in your practices who are already able to get this vaccine. Now, between the 2 vaccines, there have been over 167 million doses administered in the United States as of April 7th, which is 5 million more doses than when I actually made this slide 3 days ago. So we are getting shots into arms at a very rapid pace. Now, the third vaccine is made by the pharma branch of Johnson & Johnson. That branch is known as Janssen, but today I'm going to refer to this vaccine as the J&J vaccine or the Johnson vaccine. This is a viral vector vaccine, and it's a 1-dose regimen. Now, this vaccine was studied really during a different time period in the pandemic compared to the mRNA vaccines. So it's hard to really compare the safety and outcome information of these studies to the mRNA studies. And so we'll talk a little bit more about that in a few minutes. It's been authorized for use in the United States for patients 18 years of age and older, and over 4 million doses have been administered so far. Now, there are two other vaccines undergoing phase 3 trials here in the United States. I'm not going to spend a lot of time on them today, but I did want to make sure I mention them. There's the AstraZeneca vaccine, which, like the J&J vaccine, is a viral vector vaccine. It has it's 2 doses with a 28-day interval, and we only have some preliminary information about efficacy from the U.S. trial, and we really haven't seen a lot of the data for that one yet from the United States. And then the final vaccine is the Novavax vaccine, and this vaccine is a protein-based vaccine candidate with efficacy data from the United Kingdom of about 89%. But again, we haven't seen, even though the trials are done enrolling here in the United States, we really haven't seen much of the data on this one yet either. It is a 2-dose vaccine with a 21-day interval. So I think to be able to talk with patients and parents about the vaccines, we need to understand a little bit about more about how they work. So I apologize now, but I'm going to probably end up oversimplifying this a bit because I think this could be a whole lecture in itself. But let's start with the mRNA vaccines. So Pfizer, BioNTech, and the Moderna vaccines. Now, while mRNA technology seems like new technology, we have to remember that people have been studying and learning about mRNA and mRNA vaccines for over 25 years. So even before the pandemic, there have been preclinical and clinical trials that have showed safety and efficacy and some immunogenicity data. And all that work really ended up paying off at just the right time when the pandemic hit. And as I suspect we'll see, this mRNA vaccine technology is really going to revolutionize vaccine technology for years to come. So how do they work? Well, they start with mRNA, which, as we all know, is the molecular blueprint or template for proteins. The mRNA that they start with in this case is one that encodes our antigen of interest, which in the case of both mRNA vaccines is the SARS-CoV-2 spike protein. Now, this mRNA coding the spike protein is then packaged in a lipid nanoparticle, which protects the mRNA and is the vehicle for which to get it into our cells. Pfizer and Moderna do use different lipid particles, so I'm not going to go into that information right now because it's proprietary, actually. But the mRNA really cannot be integrated into our host genome, and it's degraded quickly, so there is no risk of it integrating into our own genetic material. Now, once the mRNA is inside of our cell, our own ribosomes take that mRNA and translate it into spike proteins. These proteins are then displayed on the antigen-presenting cell surfaces of our dendritic cells of our arms, where they can then be detected by the immune system and trigger an immune response. And because our own cells make the protein and present it, the immune response is robust. And I'm not going to go into the immunology of all of it right now, but just know that this immune response, it includes killer T cells, helper T cells, as well as antibody-producing B cells. And this is probably why, as we'll get to later in the talk, these vaccines tend to be fairly reactogenic. They are really stimulating a robust immune response, which is good. Now, moving on to the viral vector vaccines, which the only one on the market, or the only one authorized in the United States right now, is the J&J vaccine. Now, viral vectors really aren't new technology either. We've been working with and producing viral vectors since the 1970s. And basically, to make a viral vector, you start with a virus. And in the case of the J&J vaccine, that virus is an adenovirus known as adenovirus 26. And we take out all of the genes from that virus that make it cause disease and make it be able to replicate. So now it's like a shell of a virus in some way. So it can't replicate, it's not live, and it can't cause disease. Once scientists remove the genes that allow the virus to replicate or cause disease, they then put a gene in that viral vector genome that encodes, again, an antigen of choice. And in this case, like the mRNA vaccines, this is the SARS spike protein. But different from the mRNA vaccines, it's actually the DNA or the gene that encodes it and not the mRNA template. Now, this spike protein gene then takes a ride in the viral vector, which acts as the delivery system to our own cells. And so this is how that spike protein gene gets into our own cells. The human cells take up the viral vector, and again, using our own protein-making machinery, they take the spike protein gene, transcribe it into RNA, and then translate it into spike proteins, which are ultimately presented on the cell surface alongside all the other proteins. When the immune cells detect this antigen, they're able to, again, mount a very robust immune response that includes T cells and antibody-producing B cells. The last vaccine technology that I'm just going to say a couple cents about is the Novavax vaccine, which again is not authorized for use in the United States yet, but this uses more of our traditional protein-based vaccine technology. So these vaccines already contain the pre-made pre-fusion spike protein, so the protein's already made, packaged in the vaccine with an adjuvant to help stimulate our immune systems, and ultimately injected into our bodies to stimulate an antibody-producing response. All right, so now that we have a basic understanding of how they're supposed to work, how does this actually translate into actually preventing COVID-19? So I want to start by taking a look at the clinical trial data, and I don't want to spend a lot of time on this because I know a lot of us have already seen these papers and have seen this information. In the clinical trials, the vaccines worked really, really well. And I think these incidence curves really demonstrate this best. And each of the vaccines has an incidence curve that looks very similar, as I'll show you here on this slide and the next one. And I know that when some of us maybe saw these curves for the first time in the New England Journal of Medicine, we might have cried some tears of joy because this was even better than what we expected with the vaccines. So remember, when you're looking at incidence curves like this, the cumulative incidence is on the vertical axis and time is on the horizontal axis. And you can see that over time, participants who got placebo in both the Pfizer, BioNTech, and Moderna trials, over time, the incidence of disease, so COVID infection, went up over time. But those who got vaccine in the clinical trials, actually, we did not see that same increase in incidence over time. It sort of plateaued the further you got out in the clinical, in the time after vaccination. And then this is the efficacy curve from the J&J study, which shows a very similar picture. Now, this information hasn't been published yet. This is actually from the data submitted to the FDA, so I don't have a lot of the details here, but know that the J&J efficacy is very good as well, at 66.1% compared to the mRNA vaccine efficacy from those clinical trials at 94 and 95%. Now, I think it's important to note, I did just say compared to, but we really can't, again, compare the efficacy. Both of these, or all three of these vaccines are very good. They all work very well and are all really even better than what we were hoping for. So not only did these vaccines demonstrate amazing efficacy against symptomatic COVID, but they also demonstrated high efficacy against severe disease and a more than 89% efficacy against COVID that was bad enough to require hospitalization. But the most striking information from these trials is that there was 100% efficacy against COVID-associated death. So in the vaccine trials, all three of them, there were over 103,000 subjects, and not a single person who got a COVID vaccine in any of the trials died from COVID-19. And so I think this is just really remarkable and really speaks to how good these vaccines work. Okay, so that's the clinical trial data, but I think the bigger question now is, how are these vaccines working in the real world? And so here is where we start to talk about effectiveness, which is the ability of the vaccine to prevent certain outcomes of interest in the real world. And I think a lot of questions that we had after the clinical trials were, could these vaccines prevent asymptomatic infection and spread of disease? And we also wanted to see if what we saw in the clinical trials was able to translate into the real world from a symptomatic infection, hospitalization, and death standpoint. And then as we kind of get through some more of this information, I think what's on a lot of our minds is, how do these vaccines work against the variants that we're hearing so much about in the media? So I'm going to go through, I think, 3 studies. And the first study I want to talk about is this one, and probably is the biggest one. It was published, I think, in February and came out of Israel, who was a country at the beginning of the pandemic, or at the beginning of the vaccine distribution administration process, was very efficient early on at vaccinating their population. So in this study, they actually followed a vaccinated cohort of people and matched that with that cohort with an unvaccinated cohort, and they had over 1 million people that they followed for outcomes of interest in this study. And they found that the estimated vaccine effectiveness, so in the real world, for any positive PCR, regardless of symptoms, so this is just anybody who ended up having a positive PCR, whether they were asymptomatic or not, was 92%. And this was specifically for Pfizer-BioNTech because that's the vaccine they had early on. For symptomatic COVID-19, which you can see on the right-hand side, it was 94% effective. And what's great about looking at this data is that these incidence curves look just like the incidence curves from the clinical trial. So in the real world, this translated to the same information. These are two more incidence curves from the same study that show that, again, in the real world, the vaccine was 87% effective for hospitalization, 92% effective for severe disease. And I don't have the incidence curve up here for death, but when they looked at that, the numbers were very small, and it was an estimated effectiveness in preventing death from COVID-19, even after just one dose of 72%. And data from the United States is just as encouraging. In this study, there were 4,000 healthcare workers who underwent weekly PCR testing, whether they had symptoms or not, for 13 weeks. And only 3 people who were fully vaccinated with the mRNA vaccines tested positive for COVID during that time period versus 161 positive people who were unvaccinated. And so the mRNA vaccine effectiveness of full immunization in this cohort of people was 90% against infections, regardless of whether people had symptoms or not. So I think this speaks a little bit to whether or not the vaccines are actually effective at preventing asymptomatic infection as well. And then finally, just to kind of hit this point home, I think what's really striking since the vaccines have been authorized is how they've impacted healthcare workers specifically, and how our curve in the United States has also changed since the implementation of the vaccination program. This is just looking at healthcare workers specifically, though, and I really think this is an interesting figure. It's from an institution in Texas, and basically what it's showing is that you see on the vertical axis, it's the number of positive tests for a given day, and on the horizontal axis, you've got the different days since October. Basically, a black dot represents the number of positive PCR tests in healthcare worker each day over time. This institution started vaccinating their healthcare workers on December 17th, which is denoted by the red line. And starting about 3 weeks after the initiation of their vaccination program, which is denoted with the blue line, they noted a significant drop in the number of healthcare workers who tested positive each day. And so you can see that with the downward slope of all those little black dots after the red and blues. And this is in stark contrast to the black line in the shaded area, which represents what they projected to be the increase in the number of positive tests over the same time period, which was presumably affected by vaccination. And if any of you all recall, early after we started vaccinating healthcare workers, even within our own system, there was a significant drop in the number of healthcare workers who required quarantine and isolation for exposures and positive tests after we started getting our vaccines here. So back to this slide about how effective are the vaccines in the real world. I think I've shown at least a few studies that show that they're probably effective at preventing asymptomatic infection, and we're getting more and more information that that's true, especially with the CDC kind of backing off some of the guidance for vaccinated people. They are definitely effective at preventing symptomatic infection, hospitalization, and death. But what about the variants? So variants are a hot topic right now. This is a headline from the New York Times published just yesterday that kind of stated that there is a highly contagious variant that is now the dominant variant in new cases. So we need to be able to prevent these, we need to be able to prevent infection from variant viruses as well. So that really brings me to want to just make sure we kind of talk about and understand what a variant is. So if you think about it, as a virus spreads through a population and causes more infections, it by nature is going to replicate more. And the more times something replicates, it gives it more opportunities for changes or mutations. And so a variant is just the same virus, but has, or the same kind of starting virus, but it has one or more mutations that make it different from other strains in circulation. And a variant of concern, which is the kind of the term, the phrase that we've heard a lot about, are variants that either spread more easily, cause more severe disease or death, are harder to detect by our current tests, have a less ability to be neutralized by antibodies from convalescent plasma or other monoclonal antibody products, or are not as affected by current therapies or prevented as effectively by vaccines. And I think one thing that's kind of was hard for me to understand is how do we know if the vaccines really are going to continue to be effective against the variants, especially since a lot of these variants, as I'll show you, really weren't around when some of the vaccine trials were ongoing. So a lot of the data and a lot of the outcome data and safety data and efficacy data that we see from the mRNA studies comes from like October, September, October, November, when really we didn't start seeing a lot of the variants of concern circulating in our own population until late December or early January. So one way to see if the antibodies from people, so one way to try to figure out if the vaccines work against the variants well, there's two ways. So the first way is to actually see if antibodies from people who have been vaccinated can actually neutralize and stop the virus from replicating in vitro. So that's just basically taking plasma from people who've been vaccinated, which should be chock full of antibodies, and combining it with a variant of concern in a test tube and seeing if the antibodies stop the virus from replicating in the test tube. But I think the more important way to see if the vaccines are effective against variants is to see if vaccinated people are getting sick in areas where variants are circulating. So this map shows some of the main variants of concern and the locations where they were first detected. And we don't have time today really to talk about all of the variants, but I do want to focus on B117. So we all know, probably know of this variant as it's called by the name of where it came from, which was the United Kingdom variant, because that's where it was first detected in the fall. We didn't detect it here in the United States until the end of December, but now it is the dominant variant causing new COVID infections in our country. And variant cases from B117 have been reported in all 50 states, with the highest concentrations in Michigan, Minnesota, and New York City. Now, B117 does have a large number of mutations, and some studies have shown that it may be more virulent based on hospitalizations and case fatality rates. Although I think we still need to have some more information and more studies done to kind of confirm this. We do know, however, that it appears to be more than 60% contagious than the original strains that circulated in our country earlier in the pandemic. And the recent concern, as some of you may have seen in the media, is that there's worry that it's spread more easily among children, because according to a recent news report, nearly 750 schools in the state of Minnesota have reported cases of the B117 variant over the last 2 weeks. Now, the good news, if there can be good news with this, is that so far it appears to have minimal impact on neutralization by convalescent and post-vaccination sera. And it's also the variant that made up, or this variant also made up more than 80% of the strains tested in that one study I talked about from Israel. So they were able to show really great vaccine effectiveness in their country at a time when the B117 variant was circulating. So I think that's some preliminary information that is fairly encouraging that the vaccines hopefully will continue to be effective against at least this variant. But what what if the vaccines don't end up being effective against new variants? And I think we still need to be cognizant that this might happen and that we may have to modify our approach to vaccination. The good news is that the current vaccines that are in development or have been authorized should provide at least some protection against new virus vaccines because of how they work and because they elicit such a broad immune response, as I talked about in the beginning. Therefore, changes or mutations in the virus should really not make the vaccines completely ineffective. But in the event that the vaccines are less effective against one or more variants and those variants begin to become more dominant in circulation, it still will be possible to change the composition of the vaccines over time to help protect against these variants in the future. And so what does that mean? Well, we might see the introduction of booster shots. So maybe in a year or so, we're going to need another shot of we're going to need another vaccination. Or maybe the vaccines will incorporate more than one strain when they're in development. Or even in the case of the mRNA vaccines, maybe the code will need to be altered to account for the variant changes. And what's great about this technology is that all of these things can be done and probably can be done fairly rapidly. So new information about the variants is rapidly emerging, and we need to continue our current other mitigation strategies as we learn more so as to prevent further spread and other variants from arising. So now I want to completely switch gears and talk about safety, contraindications, and precautions. In the interest of time, I don't want to talk about the phases of the clinical trials. I think most of us know this. And just know that each COVID vaccine that has been authorized has gone through all of these steps before they reach the public. Once the clinical trials have met a specific endpoint, I think we need to feel confident that the data is collated and reviewed and submitted to the FDA is all reviewed in depth. So all of that safety data, as well as the efficacy and immunogenicity data, is looked at by the FDA, and they determine whether a product can be authorized for use only once they feel like the expected benefits outweigh the potential risks. Additionally, the Advisory Committee on Immunization Practices, which is a part of the CDC, also reviews safety data before they recommend any vaccine for use. So in addition to the company and an independent safety data monitoring board during the clinical trials, they're all looking at safety data, but these two independent bodies of experts are also going to look at it before it reaches our arms. Now, Shanna mentioned that a big reason that many people don't want to get the vaccine is because of the concern for side effects. So let's talk about side effects. Side effects can also be referred to, like more in the clinical trials, as the reactogenicity of the vaccine. And most of us in this audience did receive a COVID vaccine and can probably give personal anecdotes about how we felt afterwards. And it's funny, Dan and I were talking about this earlier, and he said when people ask him about the side effects, he gets really excited to talk about the side effects because he's thrilled when we get side effects because it just means that our vaccine is working well. So I think in the case of these vaccines specifically, it is directly correlated with how well or how robust of an immune response we get. They're intended to cause this robust immune response. So I think we need to let patients know this ahead of time and know to expect some of these side effects when they get the vaccine. So in the studies, in general, local reactions were mostly mild to moderate in severity and resolved within 1 to 2 days. Pain at the injection site was the most commonly reported local reaction in all 3 of the studies. And although both immediate and delayed reactions at the site of injection were described in the studies, these included some people did get redness, induration, and tenderness at the site. Systemic reactions were common as well, with most people reporting fatigue and headaches, but myalgias, arthralgias, and fever in up to 16% of subjects after the second doses of the mRNA vaccines were also reported. Side effects or reactogenicity was more commonly reported in younger recipients than in older recipients, and more commonly reported after dose 2 than after dose 1 in the mRNA studies. In general, other adverse reactions were usually mild to moderate in intensity and resolved within a few days. There were Reportedly more adverse events in the vaccine group in the Pfizer-BioNTech study, but that's because they lumped in the reactogenicity events into that group as well. Interesting, lymphadenopathy was reported in 64 subjects in the vaccine group of the Pfizer-BioNTech study, and this again is probably related to the robust immune response that was happening in the lymph nodes after vaccination. Now, Moderna and J&J had adverse events similar in both groups, and serious adverse events across the board. There were similar rates between both the placebo groups and the vaccine receiving groups in the clinical trials, which suggested that serious events were rare, and they occurred in the vaccine participants with no more frequency than the same events that occurred in the placebo recipients. Now, the trials were large, but maybe not large enough to detect rare side effects, which is another question we get a lot from our patients and families. So there are systems in place from the FDA and the CDC that then continue to monitor the safety of the vaccines to make sure that even rare side effects are identified. The first one I want to talk about is VSafe, which is specific to the COVID vaccines, and it's a smartphone-based tool that uses text messaging and web surveys to provide health check-ins after someone gets the vaccine. And so this is self-reported data, and you're prompted to give the information by text messages. We have some preliminary information from the mRNA vaccines from VSafe, and basically they show reported events very similar to what we saw in the clinical trials. Injection site pain was overwhelmingly the most common reported event, and other events like fatigue, headache, myalgias, and fevers were also reported, and more commonly reported after dose 2 than after dose 1. I think the main surveillance system that we're all most familiar with, however, is the Vaccine Adverse Event Reporting System, which is more commonly known as VAERS. And this is a passive spontaneous reporting system where anyone, including the public, can report adverse events. I think the one thing to understand about VAERS is that it's really not a system that's designed to assess cause and effect. So it's just really a hypothesis generating system or a signal detection system so that people are looking at this information on the back end and trying to determine if there's a pattern or things that we need to be concerned about. And you can see this is some of the preliminary information from VAERS, and these are the most common serious and non-serious adverse events for the mRNA vaccines, and this is what's been reported since February. There have been over 100,000 reports for both vaccines, most of which were non-serious. There have been reports of death, and as of March 29th, over 145 million doses of vaccines have been administered, and during that time there has been, like I said, reports of death. But these are all reviewed independently and in depth by the people who review the VAERS information, and so far there has been no evidence that vaccination has contributed to any patient deaths. We know that VAERS works because early on we heard about anaphylaxis after mRNA vaccines, and this was reported within a month of the vaccinations starting in the United States. And we found that anaphylaxis is rare and really only occurs in 2 to 5 people per million doses administered. They usually happen within the first 10 minutes after injection, which is why it's recommended that people are observed following their vaccinations. Now, one question we've gotten a lot of is whether or not people can get the vaccines if they have allergies. And I think to answer that, it sort of depends. So if you have an allergy to a vaccine component or a previous dose of the Pfizer-BioNTech or Moderna vaccines, then you really shouldn't get another dose of it. And so I think it's important to know what's in these vaccines, which I've listed here, but this information is also easily accessible on the CDC website. I want to draw your attention to polyethylene glycol, which is the lipid molecule that's used in both of the mRNA vaccines, and it may be something that patients may know that they're allergic to ahead of time, and they should not get the mRNA vaccines. The J&J vaccine doesn't contain polyethylene glycol, but does contain polysorbate, which is a similar molecule, and that too is if you have a patient who has a history of anaphylaxis or severe allergy to polysorbate, they should not get that vaccine. And so the only contraindication to the COVID vaccines is if someone does have a severe allergic reaction or immediate allergic reaction to a previous dose or one of the components. The precautions, which doesn't mean that they can't have the vaccine, but that they should probably be assessed to make sure that it's going to be okay, would be that if any patient of ours has an allergic reaction to another vaccine or an injectable therapy, and so they may not know what's in those therapies that they reacted to, and so these patients may need to be referred to an allergist to try to help sort that out a little bit better. And if they do go on to get one of the COVID vaccines, they need to be observed for 30 minutes. So when it comes to allergies, it really has to do with what the patient is allergic to. And if the patient's allergic to foods or pets or insects, or they have environmental allergies, then they don't really have a contraindication or a precaution, and they can get the COVID vaccines. If they have a history of anaphylaxis to food or something like that, again, they can still get the vaccine, but they do need to be observed for a 30-minute period instead of the typical 15-minute observation period. So I really want to round out my part of the talk by talking about certain different hosts, because we get a lot of questions specific to different patient populations. So while pregnancy doesn't usually affect us when we're talking to our patients, because most of them are children, I do think we get a lot of questions about whether or not it's safe to get the vaccine if someone is pregnant. And so what I think we need to remember is that these vaccines were not studied, or pregnant people were not included in the clinical trials. And so we really do have limited data about the safety of the vaccines in pregnancy. But experts really don't believe that they pose a risk. All of the vaccines available in the United States, as I've said, are non-infectious and not live, so they cannot cause COVID. And in the case of the J&J vaccine, it cannot cause adenovirus disease in the host. So from that standpoint, and because we know other inactivated vaccines are safe in pregnancy, these vaccines probably are safe. There have also been studies done in animals and rodents that have been pregnant both before gestation and during gestation, and there have not been any fetal or developmental concerns from those studies. And then finally, the J&J vaccine, that adenovirus platform has actually been studied in pregnant women in the Ebola vaccine trials, and there were no safety signals detected. What we do know is that almost 70,000 people who are pregnant have received one of these vaccines and have reported that to be safe. So that number actually is probably even higher. VSafe also has a COVID-19 vaccine pregnancy registry, of which there's been almost 4,000 people registered. And so far, based on this self-reported information to those registries, no specific safety signals have been observed among pregnant vaccine recipients. So in general, the non-replicating vaccines overall are generally safe in pregnancy. And so when we're talking to pregnant people about whether or not they should get a vaccine, I think it's important to weigh the risks of COVID, which may be higher in some people, versus the theoretical risks of getting the vaccine. There are clinical trials ongoing. Pfizer BioNTech is planning to enroll 4,000 pregnant people in one of their vaccine trials. And ACOG and the Society of Maternal Fetal Medicine do recommend at least talking to people and offering the vaccine, but remembering that it is an individual choice. And so just really educating our pregnant women. Now, no presentation by me would be complete without talking about immunocompromised hosts, but I was told that I got to keep this to one slide. So here's my one slide. These patients were not included in the clinical trials, and so we really have limited safety and efficacy data in our immunocompromised hosts. But because the vaccines are not live and not replicating, we don't think that they are not safe. There has been one study reported in solid organ transplant recipients where no rejection or safety concerns were identified. But what they did find is that perhaps the vaccines are not as effective because of these people are on immunosuppressive medications. So what I think is really important and what I impart on all my patients is that I think they should get the vaccine, and we talk about risks and benefits, but we have to remember that the vaccines may not be as effective, and so that they need to continue to follow the current mitigation strategies. Now, finally, let's talk about the COVID vaccines in children. And I know in the interest of time, I can't go through all of this information, and we all know it. One of the things Shanna stated is that people don't think COVID affects children, but we are all practicing practitioners, and we've all seen the cases in children, including the missed seat cases. And there's been over 2.5 million cases of COVID reported in children in the United States, which is likely an underrepresentation of the actual number of cases. So children can be infected with COVID, with SARS-CoV-2. They can get sick. The rate of severe outcomes in school-age children is low, but there are health disparities in the occurrence of severe disease. And we know that Hispanic children and Black children may have an increased risk for hospitalization and ICU admission. So we don't have a lot of data on the vaccines in children. Know that the Pfizer and BioNTech vaccine does have an EUA down to age 16. And also know that both Moderna and Pfizer BioNTech have already completed their enrollment for children down to age 12. And we actually have some preliminary information from Pfizer BioNTech that with almost the 2,300 adolescents that were enrolled in that part of the study, there were no cases of symptomatic COVID in the vaccinated cohort, which is really encouraging information. The vaccine studies for the younger children have just opened and have started enrolling for both the mRNA vaccines and are in preparation for the J&J vaccines. And hopefully we're going to be having one of those studies here at our center that will hopefully open in June, which will include children under 12 years of age and will be a vaccine versus placebo study looking at efficacy, immunogenicity, and safety. We don't know what the number to be enrolled will be for that, but we are going to want to make sure that we reach out to our communities to ensure diversity. And if you know of a family that might be interested in a COVID vaccine trial, you can always email Gary Marshall, who is going to be the principal investigator of this study here. Don't send him patient information, but just let him know that you may have a family that might be interested. And with that, I'm going to turn it over to Shanna.
Thank you, Victoria. So as you begin to share information regarding the COVID vaccine with your patients and families, and you work to address questions, I think it's first important to understand what vaccine hesitancy is and what it is not. More than simple delay or refusal, vaccine hesitancy is a state of mind regarding immunization and is characterized by uncertainty, indecision, conflict, and potentially even opposition. Now, attitudes regarding vaccination, as we know, fall along the spectrum, and hesitancy represents a variety of actions. And appreciate that most people you encounter are accepting and will receive all vaccinations without hesitation. And I have seen this in the community with talking with several of you. People are very excited about the possibility of getting their children vaccinated. And recognize, too, that while the anti-vaccination movement exerts significant influence, they constitute only a small percentage of the population. So this is not where you should focus your efforts. Hesitancy implies an opportunity to be convinced, and so this is what I want to help you address in your practice. So as we go on, I want to first encourage and empower you and your role as a vaccine advocate. In multiple studies, vaccine hesitant parents uniformly cite their child's pediatrician as a trusted resource and a key factor in their decision-making regarding vaccination, and are trusted even more so than Dr. Fauci, big medical groups, elected officials, government agents, and even social media. And so all to show you that you matter in the vaccination effort, and therefore we must explore effective methods for communicating with vaccine hesitant parents. Now, the introduction of COVID vaccination has brought with it unique challenges that contribute to the argument of vaccine hesitancy. I previously highlighted some of the reasons our parents cite for not wanting to vaccinate their children, but here I want to demonstrate some of the root causes that may be contributing to that decision. And these factors include politicization of the pandemic, multiple and varied sources of information, and the amassed quantities of misinformation, which I also think leads into the less well-defined problem of asking parents to sift through scientific data to the same level and degree that we as experienced practitioners do. They see the pandemic and vaccine development in real time, and what they see they don't always like, and it can be difficult to understand without the experience and the context. And we've seen this in terms of the availability of multiple vaccines with varying efficacy. And this has created a hierarchy, if you will, of COVID-19 vaccines. And there's now a mental model of good and bad based upon the efficacy percentages alone, which, as Victoria has demonstrated, does not convey the full extent of the data. And diversity associated with COVID infection, as demonstrated by disproportionate racial and ethnic groups affected by COVID infection, has also played out in the vaccine hesitancy world, as these minority groups comprise a large population of persons who are hesitant. And I'm going to leave it to Dan to discuss how you may approach this topic. So in soliciting feedback from you in our community, several themes emerged as to how you're beginning to approach these conversations with your patients and parents. Many reported offering reassurance by referencing current data, such as that was presented by Victoria, offering personal experience with the vaccine process and side effects, describing intent to vaccinate your own children, and also beginning to engage in these conversations early and just describe for parents how vaccine rollout for the pediatric population may appear. So when I spoke to several of you, overwhelmingly, a lot of people said, can you just tell us how to do this? And I can give you some guidance, but man, there is not one correct way to engage with vaccine hesitant parents in conversation. We know that simply correcting misinformation may actually backfire because it may just entrench beliefs that we are trying to work against. And a lot of these strategies are very heavily reliant on the knowledge of the provider, which ultimately takes focus off the patient. But what I can give you that is encouraging is that a lot of the data for communicating with vaccine hesitant parents is comprised of a backbone of motivational interviewing, and this is hinging, a lot of the research and communication hinges on this principle. So it was initially developed to facilitate communication and promote change in drug addiction counseling. Use of motivational interviewing has demonstrated decreased vaccine hesitancy and improved intent to vaccinate when put into practice. So yes, good things. Motivational interviewing focuses on evaluating the source and strength of a patient's concerns and redirecting the conversation in a way that promotes behavioral change through their own internal motivation. So not just you telling them what to do, but them deciding for themselves what's important and to help them work through this process. And you can use that to your advantage. Using this approach, you can tailor the conversation to their individual needs and avoid providing unnecessary information. And while our goal is vaccination, the primary goal of communicating with this family should be an open door policy and create this collaborative and trusting partnership that the family can call upon in the future. So using motivational interviewing as a foundation, as well as recommendations set forth in several of the research articles I reviewed, I've compiled a list of just basic skills. These are my pearls or my nuggets, if you will, that if you don't walk away with anything else, maybe one of these you can put in your back pocket. And first, I want to encourage you to be a firm advocate and establish yourself as an authority of the vaccine. I know there's a lot of information out there, but I think that more important is showing our families and our patients that you believe in what you're saying. Second, establish the patient's right to question and use this as a positive. Say, I'm so thankful you've done your research and have come prepared with questions. Let's do this together. And I think the knee-jerk reaction sometimes when you think about hesitancy is to go, oh, no. But remember that parents and patients can see that. So establishing a non-judgmental environment, encouraging your families is the best way to help them open up. Also, it's really important to just investigate the root cause of a parent's concerns, not just skimming off the top when they say, I'm concerned or I don't want it, but really trying to dig deep as to what is driving these concerns so that you can tailor the conversation to that concern specifically. And again, the goal, I want shots in arms too, but the goal needs to be a trusting relationship so your families know they can count on you in the future if they have worries. And so as you work to address these specific concerns, I know it can be difficult, but just remember that simply correcting misinformation often does very little to change attitudes toward vaccination. So to this point, use facts sparingly, be open to sharing your personal experience and anecdotes, and also be aware not to address unasked questions, because doing so may trigger new concerns the family may not have initially had and invite anxiety both for them and probably for you. Also be sure to provide families with resources that match their needs. And you will determine this based upon digging deep into what their concerns are and knowing how best to meet those with your response. And then last is setting realistic expectation. Tell them what we know, what we don't know about vaccination, be honest about the data, and acknowledge that there's just some things we're still working through. So as you approach these conversations, remember you will likely need to personalize your approach based upon the individual conversation and the family's degree of hesitancy. And I also just want to echo Victoria that we, your pediatric ID team, are always available and willing to help you. And I love talking about this stuff, so please reach out if there's anything I can do for you. And with that, I'm going to turn it over to Dan.
Thanks, Shanna. I appreciate the opportunity to talk to everyone here. Shanna and Victoria just gave us some wonderful information. We learned that the vaccine is safe and effective, and we know how to deal with people who are hesitant. I'm going to talk to you guys about something that's very near and dear to my heart, and I want to express that the only way we're going to be able to get past this pandemic is to be advocates for the vaccine and be advocates for our patients. And that's the only way we can capitalize on this wonderful data and these wonderful ways to deal with vaccine hesitancy. I'm going to take a sidestep for just a minute. I read a paper this past week. It was published within the last year, and it struck me pretty deeply, even though it was something I think I already recognized. And it may be something that all of you kind of recognize as well. Patients do better, and they seem to indicate that they have better experiences when they have physicians who look like them, who are the same race as them. We need more diversity in medicine, and we need it now. However, I am going to talk as a white, privileged male doctor on issues that I am not an expert on, because it's my responsibility, as well as everyone else's here, to be an advocate for our patients and to be advocates now. So we're gonna quickly talk about demographics, distribution, access, and advocacy for both vaccines and the patients that are trying to get vaccinated. And I'm not going to be able to discuss hundreds of years of systemic racism in 4 minutes. I'm not going to be able to address all of healthcare inequities in 4 minutes, but I'm going to do my best to at least raise the points. The pie charts below, I'm going to walk you through. The dark pieces of pie, that say very confident, those are small numbers, 11 and 16%. Those are Black and Hispanic adults that felt confident that the trials for the COVID vaccines would take their community's interest into consideration appropriately. And as an advocate, we have to realize that advocacy starts from the top and from the beginning, and that's where the trials begin. The trials need to be equitable, and people weren't so sure that was going to happen. We had great data, but people weren't confident. And what did the trials show? Well, maybe their fears were founded in some truth. The U.S. population has 12% Black people, and the Pfizer and Moderna trials only included 10% of their population as Black people. That's a 20% difference, and that's important. That's stark, and it means something. And when you have inequities from the beginning, it has a trickle-down effect. There are different groups that are distinctly more hesitant than others. And I'm not going to get into all the details right now because everyone has people who are hesitant. Every group has people who are hesitant in it. But in general, and it is a generalization, people who identify as Republican, people who identify as rural dwelling, people who identify as Black, and even healthcare workers are hesitant. And hesitancy has real-world negative consequences. The CDC just published an MMWR article on this, looking at different populations that were socially vulnerable, and the socially vulnerable populations were vaccinated at less rates than the populations that were not socially vulnerable. This could be due to eligibility issues or social injustices, but it doesn't really matter what it's due to because it has real downstream health consequences on our society. So if you go and talk to your friends, your family, maybe people who are non-medical, if you look on social media news, you're going to hear all about the data about the 3 wonderful vaccines we have, and they really are all wonderful. The only problem is there's some stigmatization out there. 2 of the vaccines require multiple doses in freezers, and 1 is a single dose and does not require freezing. Now, the single dose vaccine, the Johnson & Johnson vaccine, is being portrayed in the public by people who are not scientists as a worse vaccine or a vaccine for the poor. That is simply wrong. And it hurts the message that everyone needs to be immunized regardless of what brand you get. We need to have a very consistent message. And the message is the key to this whole part of my lecture. We need to have a strong message of science. And science is wonderful, and we can learn science from journals and grand rounds, but to be honest, the public isn't watching this grand rounds, only you guys are. The public looks at the stories of people getting the vaccine and doing well. They look to popular media, and they look to community leaders. I'm new to the community, and very quickly I tried to get involved in advocacy here. I worked with an organization called Christopher 2X Game Changers to work on a campaign in town for masks for kids, and we did a wonderful job really providing masks for people who didn't have them. People are doing advocacy work right now as we speak in our own community, and we all need to get involved. I listened to a podcast the other day, and one line stood out for me from a doctor out of Maryland named Stephen Thomas. He said that the way to getting in line should not require getting online. And I've talked to a number of patients who say that they are worried about getting vaccinated because they don't have a smartphone or they don't have internet access. And that's simply not the way it should be. Literally right before this presentation, I opened my email, and I got an email from the state of Rhode Island where I just trained, and it said, urgent vaccine update alert. And it was all about how the way to sign up and register to get a vaccine just changed. And you know what? I'm lucky that I got that email, but if I don't have email or I don't have a data plan, I would not have known that. And then once we get people access, we have to be able to speak to them in their language. And I don't mean English or Spanish. I mean the way they look at vaccines. Some people look at getting vaccinated as a personal choice, and some look at it as a responsibility to the greater population. And we need to be able to speak to all of these people. But to be honest, as doctors and as community members, we can't make this a personal choice. We need to make it a responsibility, and we need to tell people that it's their responsibility to get vaccinated, because that's the only way the vaccine works is when everyone does it. Luckily, our advocacy is working. I'm not going to go through this in detail, but the x-axis looks at different demographics, and the y-axis looks at the amount of people who are willing to get vaccinated. And in each column, we go from September to December of 2020. The bars on top show that people are more and more willing to get vaccinated as time goes on. And that has to do with our advocacy and as the science comes out. So there is a light at the end of the tunnel, and we know how to get through this. But my take-home message is that it's not just Anthony Fauci, and it's not just Gary Marshall or the vaccine experts that we all need. We need everyone to do their part and really make sure that we advocate for our patients and for the vaccine itself. Thank you guys very much.
Okay, so we're just going to scroll through some questions right now. Thank you, everyone. Please feel free to unmute yourself if you have something you need to say before logging off. I know we were close to time. I'm just going to start from the top. Dr. Stephen, do we know the origin of the virus? Are there any variants reported in China?
I actually haven't seen a lot of information about that. I've really focused a lot of my reading on the variants here in the United States. But we know that variants happen because how rapidly the virus has been spreading and infecting other people, which continues to give it more opportunities to have changes and mutations. So I think we all expected to see the variants. And so this isn't unexpected. It's just like, what do we do about it now with our treatments and our vaccine strategies?
So Victoria, this is Gary. I answered the question in chat. But by the way, this was phenomenal. Thank you all so much. Really, and I know how hard it was with everything changing so quickly. But the WHO has opined that this virus basically jumped from bat to human through an unidentified animal host, and it was not generated in a laboratory, and it didn't come from the wet market. And the analysis of the strains has shown that the one that left China actually was a variant, and it was different from the original Wuhan strain. So yes, anywhere the virus spreads and replicates, it will generate variants.
Thank you, Gary.